Morning, Assalamualaikum everyone. So today I'm going to talk about approach to pediatric shock. Our learning objectives today will be how to define shock, know the stages of the shock, know the classification of shock, and generate differential diagnoses of etiology, know the initial management of the shock. Shock is a serious life-threatening medical condition. It is a state of poor perfusion with impaired cellular metabolism manifesting with severe pathophysiological abnormalities. It is due to circulatory collapse and tissue hypoxia. Normal aerobic metabolism is not maintained due to hypoperfusion. In simple words, shock is imbalance between supply and demand for oxygen consumption and delivery. Epidemiology, shock occurs in approximately 2% of all hospitalized infants and children and adults in developed countries. The mortality rate varies based on etiology and clinical circumstances. Mortality from shock is less among children than adults. For children with severe sepsis, mortality is about 10% in comparison to 35 to 40% within 1 month of onset of septic shock. Physiological shock is for every kind of shock is different. We'll go into categories later on, but basically the combination of continued presence of inciting trigger and body exaggerated and potentially harmful neurohumoral inflammatory cellular responses leads to progression of shock. For example, inadequate perfusion leads to cell hypoxia, energy deficit, it leads to lactic acid accumulation and fall in pH, which start anaerobic metabolism, which leads to metabolic acidosis, which causes vasoconstriction, failure of precapillary sphincters, peripheral pooling of blood can happen, cell membrane dysfunction, failure of sodium pump, leads to intracellular lysosome release, digestive enzymes, and which causes efflux of potassium and influx of sodium and water. Toxic substances enter circulation, capillary endothelium damaged, further destruction, dysfunction of cell deaths. Few terminologies before we proceed, you need to know about like blood pressure. Blood pressure is cardiac output multiplied by into systemic venous resistance, and cardiac output, which is systolic volume multiplied by heart rate. Stroke volume also depends on preload volume of blood present in ventricle before contraction, reflects patient's volume status. After load, the resistance to ventricle ejection, two variables, vascular tone and transmural pressures, and myocardial contractility. Many factors, including coronary perfusion, baseline myocardial function, use of cardiotonic medication can affect this. Another thing about regarding American Heart Association pediatric advanced life support tells us the formula to determine if patient is hypotensive or no. So it should be less than 5th percentile. How to calculate it is for 1 to 10 years, you have to multiply age into 2 plus 70. If more than 10, you have to have minimum 90. Below that, you will consider as hypotension. Stages of shock. There are 3 stages of shocks. Compensated, vital organ function maintained, BP remains normal, only heart rate increase. Uncompensated, you have hypotensive microvascular perfusion becomes compromised, organ and cellular function deteriorates, hypotension develops. Irreversible, when inadequate perfusion of vital organs, irreparable damage that cannot be prevented. Types of shocks, etiologically, there is hypovolemic shock, cardiogenic shock, distributive shock, which is further divided in septic, neurological, neurogenic, and anaphylactic shock, and obstructive shock. To summarize, in very simple terms, tissue perfusion is maintained by the pumping action of heart, which drives the blood through the vascular symptoms. Hence, the inadequate tissue perfusion will result when any of these components is compromised. Consequently, hypovolemia or decrease in intravascular volume results in hypovolemic shock. Inadequate pumping function results in cardiogenic shock. Increase in capacity of vascular system results in relative hypovolemia. This is referred to as distributive shock. Initially, with the help of compensatory mechanism, blood pressure are maintained, but as it progresses without any intervention, decompensated shock develops and further leading to multi-organ dysfunction syndrome. Hypovolic syndrome shock, most common form of shock worldwide, results in decreased circulating volume, decrease in preload, decrease in stroke volume, and resultant decrease in cardiac output. Etiology, most likely in blood loss, hemorrhage is there, plasma loss in case of burns, nephrotic syndrome, water electrolyte loss in case of vomiting, diarrhea. Clinical history of vomiting, diarrhea, trauma, or blood loss, signs of dehydration, dry mucous membranes, absent tear, decreased skin turgor, urine output, hypotension, orthostatic or normal hypotension, tachycardia without sign of congestive heart failure. Most common cause of shock due to trauma in hemorrhagic shock, site of blood loss obvious or concealed if there is liver injury, spleen, intracranial, GI, long bone fracture. Hypotension, tachycardic, and pallor patient will be there. Patient present with an obvious history, but in child abuse, history may be misleading. Hypovolemic hemorrhagic shock therapy always begin with ABC, replace circulating volume rapidly, start with crystalloid, blood products as soon as available for hemorrhagic shock type and cross and first blood draw, replace ongoing blood fluid losses and treat the underlying cause. Further hemorrhage, we can classify it in according to severity. Up to 15% of fluid loss, and we will have minimal physiological changes are evident. Treatment maybe only crystalloid fluid will be enough. From 15 to 30% fluid loss, you will have mild tachycardia, tachypnea with narrow pulse pressure, decreased urine output, and mild anxiety. Crystalloid fluid or may require blood products. Class number 3, which is 30 to 40% of blood fluid loss, tachycardia, you will have tachypnea, hypotension, altered mentation, oliguria, crystalloid solution, plus patient need blood. More than 40% usually cold and pale with profoundly depressed mentation, marked tachypnea and tachycardia and anuria. Quick need of blood products, operative intervention often necessary to control hemorrhage. Distributive shock due to an abnormality in vascular tone leading to peripheral pooling of blood with a relative hypovolemia. Etiology can be anaphylaxis, drug toxicity, neurogenic injury, or early sepsis. Management, fluid, and treating of underlying cause. Septic shock, systemic inflammatory response syndrome, which was previously used. Now it is sepsis. Either or septic shock is used for pediatric population. Release of mediated release, exogenous or endogenous, which causes maldistribution of blood flow, cardiac dysfunction, imbalance of oxygen supply and demand, alteration in metabolism. Septic shock, it is a unique combination of distributive, decreased systemic venous resistance, hypovolemic capillary leak due to sepsis, and cardiogenic shock. Myocardial depression effect of sepsis. In septic shock, it is important to distinguish between inciting infection and host inflammatory response. Normal immunity prevents sepsis via toxic mediators, cytokines, and enzymes. If this inflammatory cascade is uncontrolled, it results in an organ damage and cellular dysfunction. Septic shock, it further have warm shock, which is early compensated hyperdynamic state. You will have warm extremities with bounding pulses, tachycardia, tachypnea, confusion, alteration in temperature regulation. You'll have widened pulse pressure, increased cardiac output, and mixed venous saturation, decreased systemic vascular resistance. Biochemical evidence, you will have hypocarbia, elevated lactate, hyperglycemia. Cold shock, usually it is late manifestation of septic shock, which have uncompensated stage with drop in cardiac output. Clinical signs, you will have cyanosis, cold and clammy skin, rapid thready pulses, shallow respiration. You have decreased mixed venous saturation, cardiac output, and central venous pressure. increased systemic venous resistance, thrombocytopenia, oligouria, myocardial dysfunction, and capillary leak. Biochemical abnormality, you will see metabolic acidosis, hypoxia, coagulopathy, hypoglycemia. Cold shock rapidly progress to multi-organ system failure or death if untreated. Multi-organ system failure leads to coma, acute respiratory distress syndrome, chronic heart failure, renal failure, ileus or GI hemorrhage, DIC. More organ systems involved, worse the prognosis. Therapy, same thing, ABC, you start fluid, appropriate antibiotic treatment of underlying cause. Cardiogenic shock, myocardial contractility is affected, leading to systolic or diastolic dysfunction. Etiology can be arrhythmia, congenital heart disease, cardiomyopathies, infected, dilated, or restrictive, metabolic or ischemia, drug intoxication, or in case of trauma. In cardiogenic shock, you will have tachypnea, poor extremities, poor capillary filling time, poor central and peripheral pulses, declining mental status, and urine output. On examination, you will have enlarged liver, gallop rhythm, murmur, rales. If chest X-rays obtained, you will see enlarged heart and pulmonary venous congestion. Management of cardiogenic shock, correct dysrhythmia, optimize preload, improve contractility, reduce afterload. To minimize cardiac work, you have to maintain normal temperature. Sedation might be done, intubation or mechanical ventilation, and to correct anemia. Obstructive shock, mechanical obstruction to ventricle outflow. It can be due to congenital heart disease, massive pulmonary embolism, tension pneumothorax, or cardiac tamponade. Inadequate cardiac output in spite of adequate preload and contractility to treat underlying cause. This is just brief about dissociative shock. It is inability of hemoglobin molecule to give up the oxygen to tissues. Etiology can be carbon monoxide poisoning, methemoglobinemia, dyshemoglobinemias. Tissue perfusion is adequate, but oxygen release into tissue is abnormal. Early recognition and treatment of the cause is main therapy. This is just brief types of shock, pathophysiology and signs of symptoms. In hypovolemia, you will have decrease in preload, decrease in cardiac output, increase in systemic venous resistance, intravascular volume. Signs and symptoms, you will have increased heart rate, decreased pulses, dry skin, sunken eyes, oliguria. Distributive shock, you will have decrease in afterload. In case of anaphylactic, you will have increased cardiac output and decreased systemic venous resistance. Signs, you will have angioedema, low BP, wheezing, respiratory distress. Spinal, normal cardiac output and decreased systemic venous resistance you will be having. Low BP without tachycardia, paralysis. Septic, you will have variable. In early stage, you will have increase of cardiac heart rate, decreased pulses, and late you will have decrease in cardiac output even. Cardiogenic, you will have decrease in cardiac output, variable systemic venous resistance. Normal to increase heart rate, decreased pulses, jugular venous distension will be there, murmur or gallop, and hepatomegaly will be present. We can further distribute shock into based on specific mechanism and treatment. Causes that require primary volume infusion, for example, in hypovolemic, GI, or hemorrhagic and traumatic, require an improvement of pump function, for example, in cardiogenic and late septic shock, require volume support and vasopressor support in case of septic shock or anaphylactic shock. Require immediate relief from obstruction to cardiac output for in case of pneumothorax or cardiac tamponade. Cellular poison requires specific antidotes, for example, in case of methemoglobinemia and cyanide. Early signs, like we have discussed before, as compensated, you will have increase in heart rate, poor systemic perfusion. Late signs, you will have hypotensive, weak central pulses will be there, altered mental status, and hypotension. will be there. Septic shock is very commonly we see in pediatric population. You will have hypotension, maybe early, and poor and organ perfusion may be present despite good skin perfusion. Hypotension is still a sign of decompensation. Sepsis is most common etiology of distributive shock among children. This is the same thing. Capillary filling time in case of shock, septic shock, for example, we have cold shock. It in the late phase will have more than 3 seconds, and initial phase early sepsis will have flush or brisk capillary filling. BP interpretation, systolic blood pressure used for diagnosis, systolic BP lowest acceptable as mentioned before to calculate mean blood pressure, better indicator of tissue perfusion, not affected by cuff size, artery chosen. How we calculate mean arterial pressure? It is diastolic plus 1/3 of pulse pressure. For adequate tissue perfusion, we have to maintain for 1 month to 3 years old at least more than 50 mean arterial pressure. And more than 3 years, it should be more than 60 millimeter of mercury. Diastolic blood pressure requires for coronary perfusion. Minimal diastolic tolerated, it should be more than 25% of systolic blood pressure. Capillary refill time, normalization of systolic blood pressure for age and capillary refilling time less than 3 seconds, reduced mortality as compared 5.06% versus 16.37%. 37%. Type of shock, further we can recognize base of the pulse pressure. If there is narrow pulse pressure less than 25% of systolic, prolonged capillary filling time, hypovolemic shock, it can be in hypovolemic shock, cardiogenic shock, or cold shock. Wild blood pressure, more than 50% of systolic, it can be brisk capillary filling time, high cardiac output with vasodilation, usually seen in warm shock or early sepsis. Can we differentiate clinically? We can, in some cases, like in case of hypovolemic shock, narrow pulse pressure is apparent. So we have some apparent loss of fluid externally or third person with usual normal consciousness unless severe. Distributic shock, you will have wide pulse pressure, bounding pulse is disproportionate, tachypnea and tachycardia. Cardiogenic shock, you will have narrow pulse pressure, no apparent volume loss with severe tachycardia, rales in chest and grunting. Early diagnosis requires high index of suspicion. So diagnosis made through physical examination focus on tissue perfusion. Hypotension is usually a late and pre-morbid sign. Initial evaluation, physical evaluation finding may be neurological. You have fluctuating mental status, sunken frontale. Skin extremity will have color, cool, pallor, mottling, cyanosis, poor capillary fill, weak pulses, poor muscle tone. Cardiopulmonary, you can have hyperapnea, tachycardia. Renal, you can have scans, concentrated urine. The management generally, it is ABC, airway if not productive or unable to maintain, intubate, breathing, always give 100% oxygen initially to start, and saturation monitor, circulation, establish IV access rapidly, cardiac monitor, and frequent BP check. Pediatric assessment triangle provides a quick evaluation. You can check about appearance, circulation, and breathing. History is very important to determine what kind of shock is there. If you have history of injury, you can think of hemorrhagic shock or hypovolemic shock. History of fluid loss in GI, you can think about hypovolemic shock. Fever, immunocompromised, you can think about sepsis. Exposure to an allergens, you can think about anaphylactic shock. Toxin exposure, dissociative shock. Chronic heart disease, you can think about differential as a cardiogenic shock. Risk of adrenal insufficiency, you can think of catecholamine or fluid refracted shock. Goal is to increase oxygen delivery and decrease oxygen demand. For all children, we have to start oxygen, fluid temperature control, correct metabolic abnormalities. Depending on suspected cause, you can start antibiotics, inotropes, mechanical ventilation. This is just a brief classification how to approach a child of undifferentiated shock. So you can ask yourself a question like, does children have a history of trauma? If yes, you can think about hemorrhagic shock, obstructive shock, tension pneumothorax, cardiac tamponade, cardiogenic shock, neurogenic shock. If there is no history of trauma, you can ask the history of there is any history of fluid loss, vomiting, diarrhea, polyuria, as in decay, hematemesis, hematochezia. If it is yes, you can think about hypovolemic shock, gastroenteritis, decay, third space losses in as in bowel, obstruction of toxins, non-traumatic hemorrhage such as GI bleed. And if there is no fluid loss, you can ask about fever, hypothermia, or patient is immunocompromised. If yes, you can think about septic shock. If there is abnormal cardiac exam, you can maybe have history of excessive respiratory effort, prolonged feeding time, poor weight gain, excessive sweating, frequent respiratory tract infection. If that even in case no, then you can think about allergen. If there is any exposure to allergen, wheezing, urticaria. If yes, you can think about anaphylaxis. If no, so you can other causes traumatic tension pneumothorax, massive pulmonary embolus, and renal insufficiency you can think about. Generally, laboratory studies initially you can do ABG, blood sugar, electrolytes, CBC, PT-PTT, type and cross match, and cultures should be taken on the first draw. What are targets management? Pulse rate, normal for age, mean BP, lowest normal, 5th percentile, capillary filling time, about 2 seconds, different between skin temperature and collector temperature, less than 3 degrees. Urine output should be more than 1 ml per kg per hour. If it is 2.5 ml per kg per hour, decrease intake. Improved mental status, lactate normal value within 6 hours, central venous oxygen saturation more than 70%. Management of volume expansion, optimize preload, normal saline, all lactated, single lactate, except for myocardial failure, use 20 ml per kg every 2 to 10 minutes. Reassess after every bolus. At 60 ml per kg, consider ongoing losses, adrenal insufficiency, intestinal ischemia, obstructive shock, chest X-ray, may need inotropes. Approximately 3 ml of crystalloid is required to replace 1 ml of blood lost. Antibiotic and source control within 1 hour of sepsis identification. Antibiotic should be start and corticosteroids in fluid refractory catecholamine resistant shock. High dose therapy for 23 hours for first 23 hours and must be started within 8 hours. You can start mechanical ventilation, blood and plasma products, glycemic control should be there. Lack of history of fluid losses, history of heart disease, hepatomegaly, rales, cardiomegaly, and failure to improve perfusion with adequate oxygenation, ventilation, heart rate, and volume expansion suggest a cardiogenic or distributive component. Consider appropriate inotropics or vasopressor support. Persistent hypotension, if no response even after 40 to 60 ml per kg of crystalloid, start a vasopressor, norepinephrine, dopamine, and titrate to effect. Goal should be more than 60. Consider adrenal insufficiency and to give hydrocortisone 100 milligram IV. American Association of Critical Medicine for Pediatric gives a brief summary in first initial 15 minutes what steps to be needed to be taken. So in 0 minute, you have to decrease, you have to recognize, you have to identify first if there is decreased mental status and perfusion. You have to maintain airway and establish access according to Pulse guideline. Push start 20 cc per kg isotonic saline or colloid boluses up to and over 60 cc per kg. Correct hypoglycemia and hypocalcemia if present. Within 15 minutes, if you feel there is the shock is refractory to fluid, you have to establish central venous access, begin dopamine therapy, and establish arterial monitoring. If it is monitoring fluid, shock is responsive to fluid, you have to observe in PQ. If fluid refractory dopamine resistant shock, titrate epinephrine for cold shock, norepinephrine for warm shock. Catecholamine resistant shock, you're at risk of adrenal insufficiency, give hydrocortisone. If not at risk, low blood pressure, warm shock, titrate volume and norepinephrine. If low blood pressure, cold shock, systemic venous circulation O2 is less than 70, titrate volume and epinephrine should be given. Normal blood pressure, cold shock, systemic venous circulation, oxygen saturation less than 70, add vasodilator or type 3 PDE inhibitor with volume loading. If persistent catecholamine resistant shock, place pulmonary artery catheter, direct fluid, inotropes, vasopressor, vasodilator, and hormonal therapies to attain normal MAP CVP and provide more than 3.3 and less than 6.3 liter per minute per square meter. Refractory shock is still present, you can consider ECMO. Final thoughts, shock is a state of oxygen deficiency. It can be classified as hypovolemic, cardiogenic, obstructive, and distributive. Clinically, it can be recognized by increased heart rate, respiratory rate, abnormal capillary filling time, and pulses, hypotension, and altered mental status. Diastolic blood pressure and mean BP are important to manage shock, and pulse pressure is important in classification. Recognize compensated shock quickly, have a high index of suspicion. Remember, tachycardia is an early sign. Hypotension is late and ominous. Gain access quickly. If necessary, use an intraosseous line. Fluid in case of hypovolemia or hemorrhage. Administer adequate amount of fluid rapidly. Remember ongoing losses. Correct electrolytes and glucose problem quickly. If the patient is not responding the way you think he should, broaden your differential. Think about different types of shock. Just one case we'll discuss to understand if you understood what we discussed. So we have one patient, 5 years old, present with 3 days history of fever and diarrhea. He has been increasingly lethargic. He has been increasingly lethargic in the last 2 hours. Effort for peripheral intravenous access can have been unsuccessful. So initially, we evaluate according to ABC or pediatric assessment triangle. Appearance, we have seen it is she is anxious, restless, breathing fast rate, increased respiratory effort, circulation. She is pale, dry, and significant mottling, especially in hand and feet. So we have to identify if immediate intervention is needed. If we see the vital signs, the heart rate is 140, which is tachycardia. BP is 88 over 56, which is normal for the age. If we calculate, like we use the formula, it is around 80 for her age should be. Respiratory rate increased 36, saturation is 97, temperature is increased, and weight is 21 kg. So we identified that she is having fast respiratory rate. So we will start with 100% of oxygen. Okay, we'll attach to cardiac monitor, apply pulse oximeter. Now we identify what kind of shock is it. Either it is compensated or uncompensated. So in this case, compensated shock is there. Why? Because the BP is normal, only the tachycardia is present. So we identify it is compensated shock. So we'll vascular access, will give bolus of 20 ml per kg of isotonic crystalloid, maybe ring lactate or normal saline. Stop fluid bolus if sign of heart failure develop. You will have like increased respiratory distress or development of rales is present. Check point of care glucose concentration, treat hypoglycemia if needed. Assess response to oxygen administration. So after that, we assess what is that. So based of history that she is having uh, diarrhea and fever for past 3 days, plus lethargic she is now, and base of cardiac tachycardia, we think of that she is in compensated shock. But what kind of compensated shock it is? Yes, Doctor. Hypovolemic, compensated, or all right. But further, we can discuss that if she have septic shock, it will be in our differential diagnosis. So this is just as per American Heart Association management flow chart for shock. So initially oxygen pulse oximeter, ECG, IV, IO access, BLS as indicated, point of care oxygen testing. In hypovolemic shock, in case for non-hemorrhagic, 20 ml per kg normal saline lingual lactate, considered colloid. Hemorrhagic controlled external bleeding, 20 ml per kg normal saline. Transfuse PRBCs if indicated. In case of distributive shock, septic shock, management of septic shock is there, anaphylactic IM epinephrine or auto-injector if there is present, fluid policies, albuterol, antihistamine, corticosteroid, epinephrine infusion in case of anaphylactic, severe anaphylactic shock. Neurogenic, in case of neurogenic, you give a bolus of fluid and plus vasopressor. Cardiogenic shock, you can treat for bradycardia or tachycardia. Chronic heart disease, myocarditis, you limit fluid boluses, you start with a vasoactive infusion and to consider expert consultation. Obstructive shock in ductal dependent PAD, you can give prostaglandin, expert consultation shall be there. Tension pneumothorax, needle to decompression tube tracheostomy. Cardiac tamponade, you can do pericardiocentesis and fluid. Pulmonary embolism, fluid with considered thrombolytics, anticoagulants, and expert consultation. These are my references. Thank you.